The following podcast is part of a certified educational activity titled Improving Care for Pediatric and Adult Patients with Eosinophilic Esophagitis. Expert insights on the latest evidence for targeted therapy. Access the entire activity and complete the post-test at peerview.com/QQD860. Downloadable slides and practice aids are also available.
Hello and welcome to this activity on improving care for pediatric and adult patients with eosinophilic esophagitis. I'm Catherine Peterson from the University of Utah, and joining me today is Arjan Brednerd from the University of Amsterdam.
Thank you. Glad to be here.
So our goals for today, both Arjan and I have goals for today for you, and that's to improve the knowledge on the latest clinical evidence regarding efficacy and safety of targeted therapy for EoE. And we want to provide you with the guidance on applying the latest clinical evidence on targeted therapies and expert recommendations for treatment plans for patients with EoE. And with that, I'm going to turn over the program to Dr. Brednerd.
Thank you, Kathy. So let's start and have a look on the latest evidence for targeted biologic therapy for EoE treatment. The pathophysiology of EoE is complex. This is a Th2-mediated condition that is marked by infiltration of eosinophils into the esophagus. But there's activated Th2 lymphocytes and increased levels of Th2 cytokines in the tissue, and that results in the chronic esophageal inflammation and dysfunction. Key cytokines here are IL-4, IL-13, and IL-5, and more upstream, IL-33 and TSLP. So why biologics for EoE? What kind of patients could benefit there? So there's the corticosteroid refractory patients. There's patients that have a corticosteroid intolerance or side effects of previous therapy. There's patients that have multiple forms of atopy for which a single systemic treatment may work. And there's practical benefits of weekly rather than daily therapy that may improve their therapy adherence to treatment of patients. Dupilumab is an anti-IL-4 receptor antagonist. So it blocks the IL-4 pathway, and that results in an effect on B cells, T cells, monocytes, eosinophils, and fibroblasts. But it also blocks a shared receptor on the IL-13 pathway, and therefore has an effect on epithelial cells, smooth muscle cells, fibroblasts, monocytes, and activated B cells. Dupilumab is approved in the US, UK, Europe, and some other countries for treatment of moderate to severe atopic dermatitis, moderate to severe asthma, chronic rhinosinusitis with nasal polyps, prurigo nodularis, EoE obviously, and eosinophilic COPD. So I'd like to discuss with you the highlights from the UEGW that was held in October this year in Vienna. And Dr. Peterson will discuss highlights from the ACG that was held in Philadelphia. And here's results from a subgroup analysis from the pivotal dupilumab study. It was shown that dupilumab had effects regardless of baseline disease duration. So patients that had short-term disease duration, less than 5 years, were compared with patients with a moderate disease duration between 5 and 10 years, and those that had more than 10 years of EoE. And it appeared that the effect of dupilumab over placebo did not differ between these three subgroups. So there was an equal effect on histology, symptoms, and endoscopic features of dupilumab.
At ACG, we actually had something similar. So sometimes the surrogate for duration of disease, we think of being an esophageal stricture that needs dilating. And so at ACG this year, Evan Dellin presented a group or did a subgroup analysis looking at the dupilumab data and said, okay, well, if you had a history of an esophageal dilation, would you still respond as well as if you didn't have an esophageal dilation, assuming that maybe that fibrostenotic disease would be represented by patients with esophageal dilation? And if you can see that on the left side, it looks like really the response was equal between these two subgroups. So very similar to what Dr. Brednerd presented about UEGW, this is very similar to what we present in ACG, that even this subtype of eosinophilic disease responds equally well to dupilumab therapy. This one I really enjoyed seeing coming out of ACG. This was a follow-up study where they looked and they wanted to see, Evan Dillon presented this one at American College of Gastroenterology just a few weeks ago. And they wanted to see, because a lot of times your patients ask how soon do you feel better? Like, how soon am I expected to feel better if you're about to give me this therapy? So they looked at that in the open label trial, and they took basically the two different arms, the part A to C and the part B to C. And they said, okay, as soon as we start treating these patients after that first 24 weeks of therapy, and we start giving you then dupilumab 300 milligrams weekly, how soon do we notice a statistically significant difference in dysphagia scores? And they noticed that as actually as soon as 4 weeks. And 4 weeks is really when they did that first assessment. So by that first assessment, 4 weeks after starting dupilumab, they noticed a significant difference in dysphagia scores. So that was pretty quick for the people to notice the difference. And this is something that's really, I think, beneficial for clinicians to talk to with their patients, that we have this data now that we can express.
And this is data from the EoE kids study, a study where dupilumab was investigated for efficacy and safety in children with eosinophilic esophagitis. And a subgroup analysis was done similar to the study in adults, where prior use or prior inadequate response, intolerance, or contraindications to swallow topical steroids was compared to those that did not have prior topical corticosteroids. And results from the study show that was an equally high response rate in those that had exposure to swallowed steroids and those that did not have exposure to swallowed steroids, both much better than placebo.
And then at American College of Gastroenterology, they presented another very interesting study where they looked at a subset retrospectively that of children greater than 12 that had histopathologic confirmed eosinophilic esophagitis. And they looked at the patients that then went on dupilumab and those who reached disease response on weekly dupilumab. There was a subset of them that then the dosing was spaced to every other week. And that's kind of the dosing that we use for some of these other conditions, such as asthma. They did a follow-up endoscopy with biopsies and wanted to see how well could they maintain response. And if you look at this table, you can see that a majority of the patients, even if they downgraded or reduced the frequency of their dupilumab, still managed to maintain a good histologic response, a good endoscopic response, and definitely excellent symptomatic response. So it shows that you can start patients on this weekly therapy. And we can talk a little bit later about sometimes some of the patients experience, a little bit of discomfort with the injections or something. If you want to try to downgrade, it looks like that's potentially feasible in your patients, that it is reasonable to consider maybe reducing the frequency after you achieve histologic response, symptomatic response, and endoscopic response in your patients.
Let's talk about another monoclonal antibody, cendakimab. This is an agent, a recombinant humanized monoclonal antibody, which is highly selective for IL-13. And it inhibits the binding of IL-13 to the IL-13 R1 and R2 receptors. And it is administered as a weekly subcutaneous injection. Let's look at the results from the phase 3 trial. So this was a large multi-center randomized double-blind placebo-controlled study in patients with active EoE, and they were randomized to receive cendakimab at 360 milligram weekly for 48 weeks or 360 milligram cendakimab weekly for 24 weeks, followed by cendakimab 360 every other week for 24 weeks, or placebo. And co-primary endpoints of the study were mean change of baseline to week 24 in dysphagia days, and the proportion of patients with eosinophil histologic response defined as a peak eosinophil count of 6 or less at week 24. And obviously there was also assessment of the safety. And the study showed that cendakimab had a significant improvement in symptoms and histologic and endoscopic feature. Here is the 24-week results, and you can see a change from baseline in dysphagia days, larger with cendakimab than with placebo, and about nearly 30% of the patients have a histologic response defined as an eosinophil count of 6 or less after 24 weeks. Furthermore, a change was seen in endoscopy and in more broader histopathology scores such as the EoE-HSS. Cendakimab also maintained statistically significant improvement in EoE through 48 weeks. There's more data shown here. Both the histologic response is significant after 48 weeks, as well as symptoms, and also the secondary outcomes such as endoscopic response and more broader inflammation in the esophagus. Cendakimab also had a favorable safety profile, and adverse events were not more common in the patients that received cendakimab versus placebo. Also data from another drug, etrasimod, which is an oral agent that affects the S1P receptor modulator. Here's primary results from the phase 2 Voyage study. And this study shows that indeed the etrasimod has a significant effect on both symptoms and histology in patients with EoE and a favorable side effects. Although there were a lot of side effects mentioned, these were merely mild and occurring in similar rates in patients that received etrasimod as those that received placebo.
Less of a targeted therapy, but actually a therapy that commonly we use in EoE was also presented at American College of Gastroenterology, and that's budesonide oral suspension. And what they did is they actually looked at a post hoc analysis from phase 2 and 3 trials, and they just wanted to look to say if you took like a cumulative kind of dysphagia score and you looked at 14 days or 7 days, did you still see significant symptomatic improvements compared to placebo? And for how long did you notice this? So what they noted is that on budesonide oral suspension dose of 2 milligrams twice a day, that as early as 4 weeks, patients noted symptomatic improvement, and this was sustained out to 12 weeks. And this included symptom analysis looking at prorated 14-day and 7-day dysphagia scores. So it does show that there was some efficacy there that was prorated out for 14 days and then lasted out for a 12-week period with a combination when they looked at this post hoc analysis between the phase 2 and phase 3 trials. There are other emerging targeted agents, so agents targeted to specific aspects of eosinophilic esophagitis. And as Dr. Bredner talked about earlier in the presentation, there's multiple different pathways that we can look at and we can try to manipulate to achieve some sort of symptomatic, endoscopic, or histologic response in these patients. Currently, there is a phase 3 study called the Crossing Trial that is studying tezepelumab, which is an anti-TSLP that Dr. Brenner mentioned is kind of one of the first kind of phase alarmins that's involved in initiating esophageal eosinophilia. There's also barzolvolimab, which is anti-KIT antibody, and this actually will inhibit mast cells, and that's undergoing a phase 2 trial called the Evolve trial. There's something called IRL 1104, which I'm sure will obtain a different name down the road, which is a very interesting immunoregulatory protein. It's a chaperonin, and it has undergone a phase 2 trial with some preliminary results. And another one called Cali-002, and that's an anti-IL-15, and IL-15 has been implicated in esophageal eosinophilia as well, and that's undergoing a phase 1 AB. And then there are case reports and other a case series that have been kind of reported on using JAK inhibitors that we often will see being used in like inflammatory bowel to treat eosinophilic disease. What is notable is that the eosinophil depleting or inhibiting IL-5 inhibiting medications, benralizumab, mepolizumab, and lirentelimab, have actually been terminated in their studies over eosinophilic disease. And much of that, the reason behind that is related mostly to a lack of symptomatic improvement. So these have been studied but are no longer being pursued in eosinophilic esophagitis. So I think at this point now we're going to talk for a little bit about which patients should receive targeted therapy. We have now a targeted therapy, we have other ones being studied. And so we need to kind of look at trying to translate this evidence that we've been discussing into how we want to approach our patients and give them the best care possible. And a lot of this is going to differ a little bit between the two of us because the United States and the European Union are different in how we approach how we allow those patients to progress through their therapy. And even in the United States, it varies based on what insurance allows. And so often that is what dictates what we do with our patients. But what is interesting is that actually at ACG this year, there was an abstract presented by Dr. Chang who talked about how that clinicians, when you get beyond treating EoE with a proton pump inhibitor, it gets a little more gray. It gets a little less certain how we need to be approaching our patients because they have so many different aspects of their disease that we need to take into consideration. I mean, patients and physicians honestly believe that we have to find a treatment that balances symptoms with convenience, affordability, the side effects, and impacts on quality of life. And so it's been nice that we've been able to review some of these side effects of these new targeted therapies. Clinicians do seem to be comfortable with PPIs, but PPIs aren't going to fix every single patient with esophageal eosinophilia. And so we need to start thinking about other therapies. Diet alternatives are viewed by physicians that were interviewed in this abstract as being challenging, rigid, and really need to be reserved for patients that are going to be motivated and willing to then take a food out of their diet and keep it out of their diet. Other medications such as topical steroids and biologics, there's just some uncertainty about using these in patients because of financial issues. How long do we use them? We don't know right now if we can down stop, if we can stop and officially stop for a long period of time. So it gets to be kind of fraught with a lot of questions when we start thinking about anything beyond giving a patient a proton pump inhibitor or a diet. And then dilation is something that physicians that were interviewed in this abstract actually said, we know that it helps with dysphagia, but we also know it does not cure the disease. And so we continue to allow that inflammation to move forward. So anyway, the summary from this study that was done by Dr. Chang that been presented at ACG is really that I think the take home point is that beyond proton pump inhibitors, it gets to be very confusing how to approach your patients. And it probably varies a lot according to kind of the phenotype of the patient and how the patient comes to you initially. But I think the next thing that we should be doing at this point is Ariana and I should probably talk about, the differences between the United States and Europe in the use of dupilumab and when we feel like we need to position dupilumab in our patients. And then maybe we could talk a little bit about our experience with side effects and intolerances. So Ariana, I'd love to get your take on the use of this targeted therapy.
Yes, thank you, Kathy, for asking. This is very interesting topic, and the European practice here differs from the American, I think. In Europe, the dupilumab is registered for patients that have insufficient control of their disease with conventional medical therapies or have side effects to these therapies. And then conventional medical therapies are usually defined as PPIs and topical corticosteroids. So it can only be prescribed in patients that already had other therapies. And that's different, I guess, to the American situation, where you can also opt or propose dupilumab as a first-line choice.
Yeah, I think with us, it's, I get dictated a little bit by insurance, right? So I definitely have patients that I want to treat probably up front with a more targeted therapy, maybe the highly atopic, the highly fibrostenotic. I do find it interesting. And so I wanted to ask you how you interpret what a steroid failure is, because I know in my population, compliance is always an issue, especially when they're feeling
Yeah,
better. And so
yeah,
I didn't know if you see that quite a bit.
yeah. We did a study on adherence to therapy in EoE patients, and this was a bit disappointing, as nearly half the patients did not have good compliance. And particularly the younger ones and those that did not have very clear insight into the long-term goals of therapy, these patients often stop their therapy or just used it occasionally. And I guess this is something that we can understand. These are young people that have busy lives with work, socially. Then they'll have to take medicine twice a day, which is quite a challenge. And their symptoms are, well, some patients have daily dysphagia, but there are also a lot of patients that feel pretty good after a while of therapy or have very infrequent food bolus impactions.
Yeah, I feel like that's so hard to do. And then as they start to feel better, you forget because you don't choke. The choking reminds you, to take your therapy. I was really interested in that abstract that they presented where they talked about even in dupilumab, like reducing the dose, because I do see some of my patients having some side effects from targeted therapy where, I've seen some joint aches and pains and some allergies, some skin disruption and stuff. So, and mostly what I see is the patients saying, I don't really want to take a shot once a week. And so the idea of maybe going to every other week is appealing to me. I don't know if that's a practice that you've considered or what kind of side effects you would think about, reducing the dose on.
Yeah, I also see side effects. The occurrence of side effects in patients is also greatly dependent on the view of the patient on that particular medicine. So, for example, I see patients that using swallowed steroids, and then they say they'll have bone pain and they're afraid of osteoporosis, or patients that say their skin feels different after using steroids because they read that in the warning sign leaflet that is accompanied with the medicine. Well, these are not side effects seen in the clinical trials.
Yeah, and what I've also noticed, and this is just off of the fact that physicians are most comfortable writing for proton pump inhibitors, what I've seen is a significant number of patients who've looked at all the sensationalism, kind of the journalism that's gone on about proton pump inhibitors and have been like, I don't want that because it's going to cause me all these side effects. So trying to even use those as first line has become more challenging for me as well. Um,
Yeah,
yeah.
yeah. Oh,
But what,
we even see patients that they read about the side effect of dementia to long-term PPI use, and they say they already have a bit of concentration problems, so they really should have another therapy.
yeah.
And so, although the label is very clear and very hard on the presence of side effects as a requirement to go to targeted therapies, in reality, this is often a challenge to interpret.
All right, so this is our current EOE suggested algorithm, and there's a newer version that's going to come out in January by the American College of Gastroenterology. But for right now, basically, what I think Ariane and I both would want everybody to do and what the guidelines are is that we confirm that this is what we think is EOE by ruling out other conditions. And then you can have that shared decision making approach that Ariane talked about with his patients, where it really depends on what the patient wants and what the patient's goals are. The favored first line initial approach is proton pump inhibitors. However, we talked about that. There's a series of patients that aren't comfortable with that. And then in the United States, beyond that, you can do food elimination diets. You can offer them topical corticosteroids, and there is now a new FDA approved formulation, the budesonide oral suspension, and there is again the oral dispersible tablet in Europe. And then in the United States, we can also offer dupilumab potentially as a first line therapy.
Yes, and in Europe, this algorithm would be different because it is definitely PPI as a first line therapy, but also the swallowed steroids could be a first line therapy since there is an approved, very effective product. And only if these are failing, dupilumab can be started. So that should be in Europe, it is below the other options. Now, the food elimination diet, that this is a therapy that many physicians regard as a very challenging therapy, both due to the problems with adherence to the therapy, but also the requirement of the high number of endoscopies that it requires, and this is often not feasible in a public hospital.
It's interesting how there is like that difference. And I wonder, if we do want to think about how we want to position dupilumab, at least in the United States, the considerations potentially for first line use would be, our patients that have the multiple comorbid atopic conditions, the asthma, the atopic dermatitis, or those that seem to want to avoid the other medications. And it seems like potentially for you, right, in Europe, it would be after they failed the other medications, then you would be able to kind of position dupilumab. Is that right?
Yes, correct.
Do you try to encourage like a certain group? Like, are you more worried if, like on the second aspect of this slide that we talk about considerations for the step up therapy, do you have certain patients that you're thinking about dupilumab, like the really highly fibrostenotic, the ones that you're dilating multiple times, or ones that are maybe malnourished, that you would think would be higher risk?
Yeah, obviously this is a very controversial topic. You could say you'll give dupilumab to patients with a fibrostenotic esophagus in order to prevent further deterioration of the esophagus. But you could also argue that you want to give it earlier in the disease to prevent this fibrostenotic condition. So I'm not sure what to recommend on this.
Yeah, I think these are all like considerations, aren't they? And then we just have to, hopefully the data will come out as time goes on and we'll have a better idea how to position this. But these are definitely ways to think about it in our population. Great.
Yeah, ideally you would know at baseline if a patient would respond to a certain therapy or has a more progressive phenotype. So you could be more aggressive in your therapy immediately up front. But this is not where we are at the moment yet.
Hopefully down the road, biomarkers will be. That's what I'm hoping. But yeah, we just don't know. Well, I want to thank everybody for joining us today and to thank you, Professor Brednerd, for providing your insights into this discussion. I always enjoy discussing EoE with you. Your insights are amazing. And both Ariane and I hope that everybody in the audience found this activity to be useful to your practice.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education, and by the European Board for Accreditation of Continuing Education for Health Professionals. This activity is supported by an educational grant from Sanofi and Regeneron Pharmaceuticals. To access all materials for this activity, visit peerview.com/QQD860.